Thanks. Hi. Good morning, good afternoon, wherever you're at. As Dr. Tupman mentioned, I'm going to speak to you about dynamic imaging for slipping rib syndrome. I've got no financial disclosures or conflicts of interest with the material in this presentation. We obtained IRB for retrospective review of the last 5 years of data that we've collected, and I'd like to thank Dr. Dane Van Tassel, Nick Schultz, and the rest of our SRS team for their support and encouragement on this project. So our objectives today, I'm going to give you an introduction to slipping rib syndrome. We'll go over the study design and protocol. I'll give you a how-to guide on how to perform the exam. We'll talk about the treatments that are involved with positive findings, and we'll do some interesting case studies, and then I'll give you the data findings on our 5-year review. So slipping rib syndrome, we abbreviate it as SRS, was first described by Edgar Cyriax in 1919. So he was a British orthopedic surgeon and physiotherapist, and he's known for his work in gymnastics and manipulative treatment. He, of course, named the syndrome after himself, Cyriax syndrome. That's its lesser known name. Today, has gone by names such as rib tip syndrome, 12th rib syndrome, and clicking rib syndrome, to name a few, which makes the search for information a little bit more complicated. Eleanor Davies Colley happens to be the first female fellow in the history of the Royal College of Surgeons, and she was the first to document the treatment of SRS back in 1922. She had two female patients, one in her 20s and the other in her 40s, that experienced increasingly debilitating pain, of which one was due to a traumatic incident. Both patients' symptoms were relieved after excision of the affected rib cartilage. She stated that had she been acquainted with slipping rib as a cause for abdominal pain, she may have arrived at a correct diagnosis much sooner. Honestly, I think 100 years later, we're still in the same darkness when it comes to this syndrome. Many of the young patients that we have imaged have been suffering for years, sometimes as much as 4 to 6 years before a diagnosis is made. So SRS is basically defined as the hypermobility of the anterior false ribs that allow for the edges of the ribs to slip under the overlying rib due to the cartilage disarticulation or congenital deformity. It usually results in a clicking or a popping sensation. It's often accompanied by pain, and there is a female predominance. So we have these detached cartilage ends that are free to move about during normal breathing, twisting, bending, never mind any kind of additional activities or sports that we put these ribs through, especially repetitive movements. So you can see how these free ends could slip under or even over a rib above. And as that happens, the nerve that courses along the undersurface of the rib gets pinched, causing a sharp stabbing type pain. So here's where the nerve lies, usually underneath. And then as you can see, once they slip under, how it could grip under the rib over here and cause that intense stabbing type pain that patients experience. So there are some challenges to the diagnosis of SRS due to the fact that there's such a broad differential of either anterior, lower chest, upper abdominal pain. So it's really a diagnosis of exclusion, and its true prevalence is unknown. Although there are some articles out there that suggest that upwards of 5% of MSK uh, diagnoses are the result of SRS. And again, many patients suffer for years with refractory pain before a diagnosis is made. So the other thing that's of interest to note is that SRS can actually affect individuals from 8 to 80 years of age. And as mentioned, females are more at risk, with some studies reporting as much as a 4-to-1 ratio. The dysarticulation can be due to either congenital malformation, direct or indirect trauma. And then patients with certain hypermobility syndromes, such as Ehlers-Danlos, may be more at risk. So the hooking maneuver is the test, the manual test that involves the examiner hooking their fingers under the suspected rib and then raising it in an upward and forward direction. The test is positive when the movement replicates the pain. And as you can imagine, this is a procedure that is not well tolerated and why we started seeing patients in our department for evaluation for slipping rib. So as a result, today our surgeons now perform more of a costal margin palpation rather than a hooking maneuver. And then based on that, they send the patients for dynamic imaging. So again, SRS is usually diagnosed through physical exam or direct palpation as we do now. Static imaging technique has very limited utility in the diagnosis of SRS, so dynamic ultrasonography has been proposed. So in 2019, we actually were able to put together our first article with a dynamic ultrasound protocol that we created for use in diagnosing this syndrome. So again, as we started to receive requests to evaluate for SRS from our pediatric surgeons back in 2017, um, due to the attempts of the hooking maneuver being very difficult to perform on some patients, we researched the topic. We determined that kind of limited data had existed, just a few articles on some case reports. And so we decided to work towards a reproducible protocol which would improve the sensitivity, accuracy, and diagnosis of SRS. We knew it would involve utilizing a high frequency linear array along with some cine clips and some dynamic motions. So initially there were four types of dynamic maneuvers that were looked at: Valsalva, crunch, a focal rib push, which we tried to or which we created to sort of emulate uh, hooking in a sense, rather pushing rather than pulling, and then any particular provocative movement that elicited pain that the patient could perform. For some patients, that meant sort of a twisting motion. We also obtained a detailed history, and we discovered many of our patients were athletes. So before performing the exam, we obtain a detailed history, like I said, of symptoms. We want to note the side, the pinpoint the areas of discomfort or pain, the type of pain, whether it's dull, sharp, constant, intermittent, if it's movement related, how long they've had the problem, what they've done thus far imaging wise, as far as treatment might be as well. Many patients are active in some sort of activity or sport. We had a lot of patients that were either swimming, gymnastics, cheer, band, softball, baseball, wrestling, rowing. I mean, just to name a few, multitude of different activities that our patients were involved in. So we set up our machines with a linear transducer using an MSK preset, and then we begin the exam by identifying the 12th rib and then moving on to the 11th rib. And from the 11th rib on to the 7th rib, we perform these various cine clips, noting any abnormalities and or positive findings along the way. So this is our worksheet, our current worksheet, where we have a simple checkbox that we use, and then some reference material on the back, which I'll go over with you in just a moment. So again, cine clips are taken at the affected ribs and we use it in a parasagittal plane. So we want to go from a lateral to a medial through the costochondral junction past the rib tips for our evaluation of morphology, or what we call at rest. And then we have the transducer in a fixed position at the rib tip with the superior rib in view while the patient performs what we call a crunch or mini crunch, and then the push maneuver are performed on the patient. So clips are done at rest, crunch, push, and then any other provocative movement that might cause slipping. And at minimum, the crunch and push maneuvers should be documented on normal exams. Any morphologic abnormalities should be noted with either static images and or cine clips. So now the technique and assessment for each maneuver. So we determined early on that the Valsalva maneuver that was originally discovered in our research review was not effective. And so therefore we eliminated it from our protocol, introducing instead our morphology or at rest, which is a sweep that we perform. And then we kept the crunch and the push maneuvers. So these three movements are evaluated at each level, again, starting at the 11th rib and then working our way up to the 7th rib. So for the evaluation at rest, imaging begins posteriorly in a parasagittal plane. We want to see the rib we are evaluating in cross-section in relation to the rib above. So in this example, the focus will be on the 9th rib. Once the rib is located, we'll see the calcified portion. And then we begin a sweeping motion, keeping the rib in cross-section and moving from a posterior to anterior in an arced fashion. So if we look at this video here on the left, uh, we see a normal negative at rest costal margin, costal morphology of the 9th rib, and we can see that the rib tip ends, and it's in good distance from the rib above. It's not abutting the rib or anything along those lines, and this is what appears to be a normal disarticulated right ninth rib. Moving over to the abnormal side here, or the positive, we can immediately see that the rib bodies and tips are coming very close to each other and slipping even under, so such that even at rest, we can tell that this is already a positive study. So the rib tip you can see is kind of pushed all the way underneath right over here. Over time, we identified that while we were evaluating morphology, that there were certain things that we could pick out that put ribs at risk. So one of the first things that we noticed was the close proximity. So as in the first image we saw, there was a nice separation. Here, this one, you can see that the rib tip comes very close proximity to the rib above. The other thing that we noted, which was of interest, was how the rib above, so rib 8 and rib 7, are barred. And so that makes them more of a fixed point, which could potentially allow for this left ninth rib to slip under during any kind of motion or activity. The other thing that we noticed also is what we called hooked ribs, and those are just sort of what I would call like a Harry Potter wand-like appearance. So they are disarticulated, they're diminutive and twisted, they're elongated. And so you can see how that would have the potential to potentially maybe hook under the rib above, making it positive. The other thing that we noticed, if you look at the video on the right, is how when we get close to the tip, we can see an increase in the intercostal muscle. Uh, and that could be an area of inflammation or an area of discomfort that the patient might be feeling and it sort of kind of pointed out to us that we noted it and said this could be something where we do see and we do happen to notice it when we have positive findings. So moving on to the next maneuver, the crunch maneuver. So in this particular maneuver, rather than us moving the transducer from a posterior to anterior evaluation, the transducer is held in a fixed position in the sagittal plane as close to the affected rib tip that we're looking to document. And again, we're oriented transversely over the distal rib tip while the patient performs what we call a mini crunch. So if we look at this particular clip here on the left of the normal side, we can see the rib tip right over here, and you can see a nice good distance. We do see a contraction of the intercostal muscles, but the rib tip does remain at a nice good distance from the rib above. Contrarily, when we look at the abnormal side, we can see that the rib tip immediately is underneath and pushed underneath the rib above. You can also see on this particular patient that the 8th and 7th right ribs are barred as well. So another finding, and you actually even see some increased echogenicity as well in the intercostal muscles there. So this motion that you're seeing of it moving actually is where you can result in a palpable click pop sound that the patients usually complain about. So the push maneuver was something that we came up with, and you can see in the image above where someone is assisting being just beyond in the center of the transducer there at the affected rib. So again, the transducer is in a fixed sagittal plane, oriented transversely over the distal rib tip. And so applied pressure is put with the thumb or index finger just posterior to the transducer, pushing inward and upward. And the idea is to try to elicit a rib slip. So here we are at the normal. You can see how we can easily push down on the rib, but even though we're trying to force an upward motion, we're not able to. And then contrarily, when we look at the opposite side over here on the right, we can see how the rib can easily be pushed underneath, the rib tip can easily be pushed underneath the rib above. And again, this may result in a palpable click pop sound as well. So treatment for slipping rib usually involves a bit of a three-step process. Usually goes from a conservative to a medical to a surgical. So with the conservative, non-invasive, we're using usually decreased activity, ice or heat, some NSAIDs, topical analgesics. Occasionally physical therapy or chiropractic manipulation will happen or will be utilized. Unfortunately, sometimes that actually does not alleviate the symptoms, but actually causes more discomfort for the patient. Most of the time, when these conservative options fail to produce or eliminate the symptoms, that's when more intervention to the area or areas is targeted with pain management treatments. In the medical treatment, it's either steroids or local anesthetics. Nerve blocks are also done. Radiofrequency ablations are done. Nerve blocks sometimes are done pre-surgically, and that's just to confirm that the diagnosis is correct and the patient does get some resolution. If those fail, or if the patient opts to, then surgery is done, and usually that either involves just cartilage excision. Occasionally, rib plating will be done, vertical rib plating, and then at that time, usually they'll do sometimes cryoablation too to sort of deaden the nerve for a period of time to allow for healing and reduction in pain management. So, when the nerve blocks prove not successful long term, or if the patient doesn't wish to proceed with nerve blocks, surgical intervention is an option. Uh, Removing the cartilage will keep it from slipping up and pinching the intercostal nerve. But if upon removing the rib cartilage, the rib itself can still sublux against the adjacent ribs, vertical rib plating can be done to limit the rib movement. So the plating material can be seen on ultrasound, which you can see in the bottom image over there with the blue arrows. And so plating is the plating material usually is covers the rib above and below, sort of as an anchor, and it can be absorbable or permanent. So once the plate is reabsorbed by the body, that usually takes about 2 years. Then what happens is that scar tissue will form to hopefully keep the ribs separated. Cryoablation can be done to minimize postoperative pain. And that is done where a probe is actually inserted into the intercostal space for 2 minutes at minus 60 degrees Celsius. This freezes the intercostal nerve, giving a temporary feeling of numbness for about 6 to 8 weeks. And it's usually performed through the same small lower costal incisions that are done in the operating room. So let's look at some interesting case studies. So our typical presentation that we wound up seeing, if I had to say the average patient, these are usually people or young individuals that will come in with long-standing unresolved pain. The pain's been increasing in severity over time. They've seen multiple different physicians and had different types of imaging studies and labs. They've been actually forced to either severely limit their activity or remove it completely. After a while, they've actually even been told that this discomfort and pain that they're having is actually in their head. And so they've wind up performing their own search of their symptoms, and then they have sought us out over time to help see if we can find out if slipping rib syndrome is the actual cause. So here's our first case study. This is a 12-year-old female with lower right rib pain that she's had for 3 years. The pain is exacerbated with walking and carrying books to school. She has a limp due to a history of right hip dysplasia that may be a contributing issue. She's tried wrapping her ribs, taking ibuprofen with no relief, and her pain's been described as persistent, sharp, stabbing pain that will not abate until she rests. She was active in ice skating and gymnastics. So here we have the right ninth rib at rest with crunch and push maneuvers. So here is at rest, and we can see the rib tip coming here and eventually knocking right into the rib above. When we look at the crunch, we can actually see the rib tip come right into the rib above, knocks right into it. And then with our push maneuver, we're actually able to push that rib tip right into and underneath the rib above. So all three maneuvers are positive for SRS of the right ninth rib. So now we're going to look at the right 10th rib at rest with crunch and push maneuvers on this patient. So we have a very similar situation here, very long diminutive rib, and we can see that it ends underneath the rib above at rest. When we look at our crunch, we also see it slip right underneath as well. And then when we look at perform our push maneuver, again, we're able to definitely not just push deep, but push upward as well. And if you look, you can actually see that increased echogenicity of the intercostal muscle as well. So all three maneuvers there were positive. So we looked at the other side, the left 10th rib at rest, crunch, and push on this patient. And again, the rib comes close and then eventually slips underneath at rest. Patient performs a crunch, and we can see that it slips under as well. And then with our push, same thing. All three maneuvers are positive for a slipping rib of the left 10th rib. So this patient had a positive R9, R10, L10 on all three maneuvers. She underwent successful nerve blocks ×2. She was pain-free for the first 9 months on the first block and then 6 months on the second. So as a result, the patient underwent surgical intervention with cartilage excision, and she's been doing well. Our second case study is a 20-year-old female with a year-and-a-half history of bilateral rib pain. Her initial injury occurred while she was participating in a 6K rowing event, where at the halfway mark she felt an actual popping sensation and bilateral rib pain, but she continued and finished the race. Kudos to her. Following this event, she had persistent rib pain with all exercises and actually had to retire from rowing. The pain occurs with sitting, sleeping, breathing, coughing, sneezing. She typically feels a popping sensation when the ribs move back into place, and she gets some relief with rib compression wrapping. So here we have the right and left 10th rib at rest, just for comparisons. So we can see the right rib. There's some increased echogenicity. And then the left rib comes close, but doesn't seem to slip under. So they sort of seem like maybe they're at risk here. So here's a crunch comparison. So here's the right side crunch, which looks normal. And then the left side crunch, we can clearly see that that slips, and that's a positive. So now we're going to look at the push maneuver. So on the right side, we're able to push down, but we cannot push up. And when we look at the left side, very easily we can push that rib up and underneath the rib above. So normal R10 push and a positive L10 push. So this patient revealed positive L10 slipping rib syndrome with crunch and push maneuvers, and she elected to undergo a radiofrequency ablation. Case number 3 is a 16-year-old male with a 4-month history of intermittent left lower rib pain that's been worsening with forward bending. He has no known injury. He does play tennis. This is a look at the left 10th rib. So this is the affected side first. So here we are at rest. So there's some increased echogenicity of the intercostal muscles. When we look at the crunch, we can see definite positive slipping. And then looking at the push, we could not achieve a positive slipping on the push. So the crunch was positive. So now we wanted to look at the comparison side. A lot of times, if one side is positive, it does happen from time to time. I'm not sure what percentage is. I don't think we looked at that information. That even though the patient may not have pain on the opposite side, that there is still slipping on that side. It can have slipping on that side. So here's the comparison. So at rest, we can see the increased echogenicity of the intercostal muscle. So and we can actually also appreciate on this side that the rib is slipping under. So even though the patient's not having pain at this time, the rib does slip under at rest. If we look here at the crunch, same thing. It definitely slips under. We can see that. Slips under and then comes back out. And then on push, once again, we see that increased echogenicity of the intercostal muscles and R10 slipping under R9. So such that on this unaffected side, all 3 maneuvers produce positive findings. So this information is good to note should the patient begin experiencing pain at a later date. So further inspection, we tried to look at the right 9th rib over here and with comparison to the left 9th rib, we can see that both 9th ribs are barred to their respective 8th ribs, but only R9 shows its tip slipping up over 8. So in this particular situation, rather than the rib slipping under, this rib is slipping over, which is still a positive finding. So on this particular patient, R10 had positive all 3 maneuvers, R9 at crunch, and the left 10th rib at rest and crunch. So as the patient was asymptomatic on the right side, they opted only for L10 nerve block at this time. So our last case study is an 18-year-old female with a history of slipping rib syndrome. She's already had previous bilateral 8 through 10 rib resection at an outside facility, and she's currently still continuing to have bilateral pain and popping sensation that basically has been debilitating her at least once per week. So we were asked to evaluate for possible recurrence of slipping rib syndrome. So on this particular patient, obviously there's no rib cartilage, so we're actually going to see the shadowing of rib, and we're going to look at our rest, and we can see how the rib tip just basically ends. There's no cartilage, and it seems to be at a good distance. When the patient performs a crunch, we're not seeing anything. And then at push, we can push down, but we're not able to push up. What was most interesting about this particular patient was that they were able to perform a provocative maneuver on themselves. And so here is the patient actually pushing her own rib, and you can see that she's able to create clearly positive slipping. So she's performing a push maneuver on herself and able to produce what we were not able to. She may have been guarding, perhaps, and that's why we weren't able to obtain that. So we looked at the left ninth rib as well. And on this particular one, we can see that the rib does appear abnormal here. We look at the crunch. Maybe. Okay, so we've got some little glitch going on over here where our crunch did not play and our push is giving us some, there we go. Maybe it's cleared up now a little bit. Uh, might have been hard to appreciate since the clips weren't playing properly, but all three maneuvers were abnormal on this. And the patient was also able to create or elicit a positive push on themselves on this side as well. And you can see how, like, you can almost literally see why you would hear that popping sensation. So L9 was positive for slipping rib on all three maneuvers. R9 was at risk with crunch and positive on the patient's provocative movement themselves, where she was able to do her own push. So the plan is for this patient to undergo cryoablation and now vertical rib plating at bilateral ninth ribs to hopefully uh, eliminate this pain that she's been having. So let's go over the data findings. So IRB was approved for our retrospective study that was performed from March of 2017 through May of 2022. Our patients underwent a detailed H&P imaging and dynamic ultrasound assessment. The exams results were compared with surgical and physical exam findings from our pediatric surgeons specializing in slipping rib syndrome to confirm the diagnosis. Our data collection included demographics, a number of evaluations, and SRS diagnosis, laterality, and surgical status. So 301 exams were performed on 227 patients, and we had positive slipping rib demonstrated in 194 or 75% of the patients. 22% of our patients underwent multiple exams that were either for follow-up, after surgical intervention, or due to symptom recurrence. The majority of our patients were female at 70%, with the average age of 17.4 years and an average BMI of 22.4. So we looked at each maneuver individually, and while specificity was high at between 88 to 93%, the sensitivity was somewhat lacking at 54 to 55%. However, when we collectively looked at grouping the maneuvers, we found much improvement. So combining all three maneuvers, the morphological assessment with the dynamic maneuvers, the crunch and push, that had the highest sensitivity at 97.4% and the highest specificity at 89.2%. So, in conclusion, SRS is underdiagnosed and under-recognized. Dynamic ultrasound imaging of the ribs has proven to be an effective and reproducible tool for the diagnosis of slipping rib syndrome. And combining, as we mentioned, morphologic assessment with dynamic maneuvers offers a higher sensitivity and specificity. This allows for expedited diagnosis and appropriate management, hopefully a reduction in multiple specialist visits and nonspecific testing. And it also gives assistance in surgical planning and improved patient outcomes and satisfaction. There are some limitations. Obviously, we were a single center design. This is a retrospective. Some of the considerations, ultrasound's technical skill dependent process, but with proper training, dynamic ultrasound can be rapidly implemented as a diagnostic standard for slipping rib syndrome. Future research is needed to validate these findings across broader populations and at other centers to explore the clinical performance of this protocol. Any questions? These are our references, and thank you very much.
Thank you so much, Monique. That was awesome. Really nice presentation and very interesting to hear your experience with this. Yeah, so we have a few minutes for kind of Q&A and discussion. If anybody has any questions, feel free to direct those to me in the chat. Our first question already came in. It's a question that I also had. I was about to ask. Could you describe your technique for accurately numbering the ribs? At least in the few studies that I have personally done, I find that very challenging to kind of morphologically define the rib numbering. What
Yeah.
is your kind of preferred technique and experience with that?
Uh, uh, Initially, one of the things that we noted was that the majority of time at actually mid axillary line is usually where we would find the tip of the 10th rib. So we kind of started, along those lines, and then through trial and error, discovering that that didn't always work and wasn't, really good practice. And we also looked at the fact that a lot of times the seventh rib was attached directly to the sternum. So that was another thing that we started and looked at. And again, that wasn't 100%, right? So what we wound up doing is we usually just basically turn the patient left lateral to cube, and we just identify the 12th rib and we go from there. And then we slowly lay the patient back and then start our exam at the 11th rib.
Okay. All right. That's very helpful. Yeah, I think I have mostly been trying to identify the seventh rib attaching to the sternum, but it's
Hmm.
just like a big cluster of cartilage right now, right there. I find it challenging to tease that out sometimes. So it's very
Yeah.
helpful.
I mean, a lot of times even, some of the patients would have had imaging, so sometimes we can take a look at the chest X-ray or look at a CT that could potentially help us out as well, as far as the way it looks.
And then similar question is, do you ever get requests from your surgeons to do preoperative marking? So we've had a couple of cases. It's pretty new for us, and I think our surgeons as well. So they've asked us. We called exam positive, and they've scheduled them for rib resections, and they've asked us to preoperatively mark the exact or the exact rib that we thought was abnormal. Do you get requests to do that, or with your experience, do they not really ask you to do that as much?
We definitely did very early on. That was something that did happen. We did go up to pre-op and help identify or mark. Over time, that ask decreased to the point where it's completely eliminated now. It's no longer an ask.
Okay, cool. And then with your level of experience now, so with how many we've done, it's generally either me or one of my colleagues that will go into the room and scan the patient with the sonographers. Are your sonographers, are you doing these exams independently, or do you have a radiologist present with you as well?
We do them independently now. In the beginning, they were always done with a radiologist. So essentially, myself and the MSK radiologist uh, would go in the room, and they would perform the push maneuver for me. Over time, I began to scan with my left hand and push with my right hand, so I was able to perform the study independently. But in the interim, what I wound up doing was just bringing in one sonographer at a time, and we usually do a tag team. So they would watch me do a few. They would assist in, getting accustomed to how to perform the push maneuver. And then we would switch roles. They would scan and I would assist them until they could do it independently. And that's pretty much how I cross-trained the department and the staff on how to do it. And then eventually, the radiologists then cross-trained each other on how to interpret the studies, or they would come in as well. And watch and observe how we did the studies. And if we had questions or concerns about an area being at risk and we felt that it might be positive or we weren't sure, then they would come in later on at that time and reevaluate that one area if needed.
Okay, interesting. I'm also curious, and Judy and Hatrie, I'm curious from you guys too. Are you guys, I'm curious how widespread this exam is being performed. Do you guys do this in LA and Pittsburgh? Or how often are you guys seeing these patients?
We've been offering it for a few years now. We have a few sonographers who are like the champions of this examination who primarily do these. I feel like they come in spurts, just like everything else. So we'll get like a bulk request of them, and then we won't do one for a while for this clinical question. But I think they're pretty challenging to do. And I like it's part of our protocol to have the patient do whatever the maneuver it is that elicits this sensation for them, which I think can be challenging to scan, but can be helpful to make that maneuver happen to see that slippage.
Yeah, so we haven't gotten many requests, if any, that I'm aware of at CHLA, but at Texas Children's, the MSK radiologists were doing it. So while I was there, unfortunately, I did not, because I wasn't part of that group. So I did not perform them when I was there, but I know they did do them. And most of the time, I think also because it was like, in like 2018, 2019, like the earlier time periods, I believe the MSK radiologist would also come in, but that's after the sonographer scanned first.
Okay, cool. And Monique, I'm sure people approach you to help with this. Do you kind of have a sense of across the country how many places are offering this?
I actually don't. I know that there are a few websites now that are specific. I think there's one called srs.org, slipping-rib-syndrome.org as well. I think there's a couple out there that have different areas and physicians that are specializing, MSK physicians that are specializing that patients can go to a resource center, for people. And it's not specific only to the US, but it's also in Europe as well. So
And
it's very interesting. I
yeah,
mean, we've had patients, I've scanned patients from Europe, from even as far away as Australia, for this procedure. And that's just mostly because our MSK surgeon actually had been on the show The Doctors years ago. I think it was 2016 or so, discussing this particular syndrome and the surgical procedure that she performed on a patient. So that's sort of how we started getting all these, patients coming to our facility.
oh, interesting. And then my last question for now is how often are you asked to do? I know you shared that one case of the post-operative examination. We haven't been asked to do that yet, thankfully. I'll have to figure it out once it happens. But how often are you guys getting those types of exams where you're asked to look post-operatively, and do you find those a lot more challenging than just doing the baseline exam?
They're definitely challenging. And one a couple of things that make it challenging, obviously, is the edema, depending on how recent the surgery is, the intervention that was done, whether they did rib plating or not. Um, the other thing that sometimes is very hard to do or hard to follow is a lot of times the surgical notes don't specifically say which ribs they are, so that can be challenging too, as well. And Patients have a tendency to be a lot more sensitive, especially if it's fairly recent. But over time we've learned how things look, and we've been able to see like if the rib plating has been cracked, or if there's a separation in it. We've had patients who they have wound up in a car accident, unfortunately, a few months after their surgery, and then had an issue with the plating, and had to go back and have things redone. Uh, the other thing too is a lot of times when uh, patients are positive but are not symptomatic, we'll get patients that come back sometimes that now are symptomatic, and then we're reconfirming uh, that they had. And so a lot of times they'll want us to look at the surgical side as well, just to make sure that that still looks good.